Good morning. It's a real pleasure for me to do this lecture in front of you today. I really love your country, Vietnam, where I've been several times. But unfortunately, even if I would have preferred to be there physically with you, I will have to do that lecture by Visio because of the story of COVID. But I will answer live all your question at the end of the lecture. So before I start my lecture, I want to disclose my conflict of interest. You have to know that I am, and I've been a consultant for many food industry and for Philip Morris, but only on smoke-free product, not on cigarettes. Obviously, as an oncologist, this would have been possible. You have to know that I was the advisor of the President Jacques Chirac between 2002 and 2006. Being in charge at that time of the French National Cancer Control Plan. We achieved a lot of improvements in the management of cancer in my country during this plan, but many of what we have been achieving were in the field of tobacco smoking. For the first time in the history of France, I increased the cost of a pack of cigarettes from 3 to 4 and then 4 to 5 euros, this within less than 2 years. This very rapid and significant increase in the cost had least to lead to the decrease of the number of smokers by 1.8 million in France. There was a huge decrease in the sales of cigarettes from 80 down to 55 billion sticks per year. So I was a real fighter against smoking and against tobacco industry. I was the one who wrote the law to ban smoking in public places. So really, I am a significant fighter against smoking. And if today I'm coming in front of you to discuss about new device to help people that cannot quit to smoke, I do that with real sincerity. So we are going to look at what is harm reduction, what we can do, what is cancer, and what are these new devices. But first of all, if we are looking at the concept of harm reduction in the context specifically of cancer, because harm reduction is a concept that can be used in nutrition, in car driving, in many other things, we have first to understand what do we know. We know two things for sure. One is we know what is a cancer. Cancer is an unlimited and uncontrolled proliferation of mutated cells, and these unrepaired mutations are usually related to the effect of an exposure to carcinogen. So, second thing we know is that cancer is a major public health issue. It belongs to a category of disease that we call NCD, non-communicable disease. And it's if you can look at the numbers published by the WHO in 2016, the global burden of NCDs, where 71% of all the deaths in the world, about 41 million deaths, were coming from NCDs. These NCDs include cancer, cardiovascular diseases, respiratory disease, diabetes, and other chronic conditions. If we look at more specifically the burden of these NCDs and the burden of cancer in Vietnam, what we can see is that 77 of every 100 deaths are due to NCDs, as I said, such as cardiovascular cancer and COPD, and 172 something thousand cancer deaths are related to cancer. Why? Because there are several very bad behaviors that are important in the Vietnamese society. First, the tobacco use prevalence, more than 22%. The tobacco use contributed to 30% of premature deaths due to cardiovascular disease, 15% premature deaths due to cancer, and 22% premature deaths due to diabetes. So the impact of smoking on these NCDs, including cancer, diabetes, cardiovascular disease, is really in Vietnam something that is very significant. If we look at the evolution of the burden of NCDs, mortality in Vietnam, you can see on that slide that in 1996, just over 40% of all deaths were caused by NCDs. But when we looked at about 20 years later, in 2016, it was just under 80%. And it is projected that in 2026, it's just 4 years from now, there will be more than 80% mortality due to NCDs in Vietnam. So we have to do something. What are the main top causes for both sex, all ages, of death in Indonesia? You can see the first one, more important than every other, is stroke. Then ischemic heart disease, so both of them is what we define as cardiovascular diseases. Then diabetes, tuberculosis, cirrhosis, and COPDs. So these are the main cause of death in Vietnam. If we look at specifically in cancer, you can see that the etiology of cancer are mainly due to lung cancer, stomach cancer, breast cancer, and then all the other cancer. So about 40%, 50% of all cancer can be just defined by lung, breast, and stomach. So now that we know these two things, the burden of cancer as a major health issue and what is the cause of cancer, we have to look at what are the conditions for a cancer to happen. As I said, there is always the concept of an exposure to a carcinogen, and that is related to what we call a dose response. What does that mean? The greater amount of carcinogen you are exposed to, the higher the risk of cancer. And this will be related either to the dose of the exposure, the duration of the exposure, or the genomic susceptibility of the exposure. If we look at the dose, here you have two parts in the slides, is the increased risk of colorectal cancer with the increased consumption of red meat. More red meat you eat, higher your risk of colorectal cancer. At the opposite, more fish you eat, which means usually that you eat less meat, more fish, less colorectal cancer. So there is a direct relationship between the quantity, the dose of this carcinogen, which is red meat, and the risk of developing that cancer, which is colorectal cancer. If we look at the duration on that slide, you can see 4 parts. Is the people smoking less than 20 cigarettes, 20 to 29 cigarettes per day, 30 to 39 cigarettes per day, or more than 40 cigarettes per day. But what is important is to look at the number of years that these people have been smoking that number of cigarettes. And you can see that longer your exposure to the carcinogen contained in the cigarette, higher your risk of developing lung cancer. And then the third part, which is the part on which everybody is working now everywhere in the world, is what we call the genomic susceptibility. You can simply describe that by saying that although 80% of all cancers will occur in smokers, only 8% of all smokers will develop lung cancer. So knowing that, what can we do? Well, we can try to eliminate the carcinogen, to use an anti-carcinogen, to reduce the exposure to the carcinogen, or to try to detect the susceptibility to these carcinogens. If we try first to eliminate, this is what we call the prohibition. In the 20s and 30s, it has been tried in the United States with the alcoholic prohibition. Did it work? Not at all. We had mafia, you had violence, and finally, at the end of the day, in the end of the 30s, they stopped the prohibition and everybody was able to drink freely again. It has been tried also with the tobacco control, which was aimed to influence the behavior related to smoking. The policies vary from one country to another, but there was a global convention that was signed on February 2005 under the patronage of the WHO to try to force each country to increase their activity in struggling against smoking. Did it work? Well, a very simple way to see that it has failed completely is to look at the risk factor for cancer for both sex and all ages between 1990 and 2019, so about 30 years apart. You can see that 30 years ago, the first cause of cancer was smoking. And 30 years later, it has changed with all the policies, the increased cost of a pack of cigarettes, the packet, the neutral packet, the policies to ban smoking, and so on. No, because 30 years later, the first risk factor for cancer is still smoking. So our policies have failed, and this is true in Vietnam, but this is true everywhere in the world. The second possibility is to use an anti-carcinogen, like a poison and an anti-poison. We know, for instance, now there has been several studies showing that if at the time you eat red or processed meat, you eat vitamin E or vitamin C or even calcium, you will decrease the carcinogenic effect of red meat and processed meat. For lung cancer, there's been a big hope in the 80s, thinking that retinoids and beta-carotene would have been able to prevent lung cancer in smokers. 2 studies have been performed, each one of more than 5,000 participants, and one is CARET, the other one is called ATBC studies. Both of them have shown that people smoking and taking retinoids at the same time not had a decrease in the risk, but an increase in the risk of lung cancer. So here, be careful not to do anything. It is not obvious that there is an anti-carcinogen. We can use an anti-carcinogen like a vaccination against HPV to try to prevent cervical cancer, for instance. But there is no something that you can eat up to now and that will prevent the risk of cancer related to smoking, unfortunately. So then the third way is to try to reduce the exposure to carcinogen, and that it comes to the new concept of harm reduction. Is it really a new concept? Not at all. The term arose in the concept of drug addiction, and this was very well explained in a paper published in the Times, London, in September 2019, where the story was reported as that in the 1980s, Mrs. Thatcher, Prime Minister of the UK at that time, introduced and pioneered a focus on harm reduction during the AIDS epidemic with needle exchange and safe havens, which resulted in the lowest rates of HIV in drug users in the world. Unfortunately, over the past 12 years, the new UK think tank called Centre for Social Justice led a change in drug policy toward abstinence-based policy. We don't want people to continue to use IV drug, and therefore we stopped in the UK to distribute clean needle and syringes. What happened? What was the outcome? Drug-related fatalities have doubled since 2011, and 1 in 3 drug-related deaths in Europe are in the UK. So we have to understand and accept that people will make poor lifestyle choices despite suffering negative health effect. So if you want to reduce the exposure to a carcinogen, now we know the concept, how can we do it in the field of smoking and cancer? For that, you must identify the nature, the production, and the exposure source of carcinogen. So the question is, how does a cigarette smoke can cause cancer? Well, this is a slide coming from the Food and Drug Administration in the US, which says that burning tobacco leaves will generate smoke. Tobacco smoke contains more than 6,000 chemicals and ultrafine particles. 93 of them are listed by the US FDA as harmful or potentially harmful constituents, what we call HPHCs. The majority, about 80 of them, are carcinogens or potential carcinogens to humans. How these carcinogens will start to appear in the smoke of cigarettes? You can see on that slide that their production is based on the temperature at which you burn the leaves of tobacco. Below 350 centigrade, you can see that all of these carcinogens, benzoanthracene, benzoapyrene, are not there. There is almost no carcinogen in heated tobacco leaves. But when you come up to more than 400 centigrade, where you are not just heating, you are burning the cigarette leaves, the tobacco leaves, then you start to see that this carcinogen will start to appear in the tobacco smoke. So the temperature is key in the production in the tobacco smoke of this carcinogen. So as we know, is that, I said that, the cancer development is a matter of dose response. The greater amount of carcinogen you are exposed to, the higher the risk of cancer. Then we come to the question, which is very often raised, is nicotine carcinogenic? So here is the list of carcinogens that have been published that are contained in the in the cigarette smoke, but what we know on a very totally demonstrated is that nicotine is the chemical that makes cigarettes addictive. That we know. People are smoking to get nicotine, but it is not responsible for the harmful effect of smoking. Nicotine does not cause cancer. And people have used, for instance, nicotine replacement therapy safely for many years. Nicotine replacement therapy, NRT, are safe enough to be even prescribed by doctors. So nicotine, whether you smoke it or you get gums or you get any way that your nicotine does not give cancer. So if we know that nicotine is not giving cancer, if we know that the carcinogen will to which a smoker is exposed to is related to the burning of the tobacco leaf, we have to consider that the best option to prevent cancer related to smoking is to quit tobacco. So quitting tobacco smoking is by far the best option. How successful have we been at eliminating cigarette or smoking? For instance, let's look at the nicotine replacement therapy or the medicines that are used to help people to quit. What we can see in the right part of the slide, a very nice meta-analysis published by Dr. Rosen, is that in fact the estimated net benefit of cessation medication, whatever, is 8% by 1 year, but by 4 years is less than 6%. So it's almost negligible. In the real world condition, the benefit is even likely lower than that 6% because of lower compliance and fewer patient-provider interaction than in trials. So stop to dream that using NRT, you are going to really get a significant number of smokers that will quit smoking. The second part to help people quitting smoking is the stigma we have as a doctor to support our patient. Both smokers and non-smokers are reporting experiencing lung cancer stigma. I told you 80% of lung cancer will occur in smokers, but only 8% of smokers will develop lung cancer. Patients with a smoking history are often seen as responsible, or even worse, deserving of their cancer. And sometimes when you take a smoking history, you may deliberately or more often inadvertently insinuate to your patient that they have to be blamed for their cancer. But again, it's not that easy to quit smoking. I mean, let me tell you, my experience as an oncologist for 50 years is not that easy. And this has been shown by a very nice study which showed that 64% of smokers diagnosed with cancer will continue to smoke until the end of their life. They just cannot quit. So about stigma and empathy. It has been evidence have shown that good or improved patient-provider communication may reduce lung cancer stigma and lead therefore to an increased patient satisfaction, an increased adherence to treatment pathway, a lower psychological stress, and therefore a higher chance to be well treated and cured and having a better quality of life. So harm reduction, as I said, is based on the idea that you have to accept some level of our bad behaviors that are inevitable. For instance, we try to minimize the harms people are suffering as a consequence and not to try to minimize directly the behavior. For instance, we use the new technology on driving. If you drive fast, we have now seat belts, airbags, disc brakes. If you have unhealthy diet, you have statins, stents, anti-aggregates. Sun tanning, you have sunscreen, and so on and so forth. So there is a possibility to decrease the impact, the bad impact of a bad behavior by using the science and innovation. Let's look at what is called snus, which is a little pouch that you put on your mouth and which deliver nicotine. There is no smoke, there is no burning at all. And there is one country that has been using snus for more than 25 years, is Sweden. And when you look at the death rate per 100,000 people attributable to tobacco, all causes of death for men older than 30, you can see in red the number for Sweden. So much lower than every other country in the world by just switching from tobacco smoke, smoking tobacco cigarettes, and using another nicotine delivery system, which is snus. There are other innovations in tobacco smoking. There are the e-cigarettes and the heated tobacco. The difference between the two. Heated tobacco, you heat tobacco in heated tobacco product, whether in e-cigarettes, you just vaporize an e-liquid. In heated tobacco product, you use tobacco, whether there is no tobacco in electronic cigarettes. The nicotine is naturally present in the tobacco of heated tobacco product, but is extracted from tobacco and added to the e-liquid in the e-cigarettes. There is no smoke on both of them and no ash on both of them. If you compare the efficacy of e-cigarettes versus nicotine replacement therapy for smoking cessation, you can see that it's a lot more efficient to use electronic cigarettes. If you look at whatever the 4 weeks, 6 months efficacy on EC-arm, which is electronic cigarettes, or NRT, which is nicotine replacement therapy, you can see that at 6 months, CO-validated reduction in smokers, you can see that only 6% in NRT, 26% in electronic cigarettes. And it's true that it's almost 2 to 4 times more efficacy on whatever criteria you are going to take. So we have seen that the electronic cigarettes are much less harmful than normal cigarettes and are more efficient to help people quitting than NRT. Now let's look at what we call IQOS, which is a heat-not-burn device. We can, in that slide, show the results of a big study made by the Japanese National Institute of Public Health, where they look at the content of different carcinogens, HPHCs, as I defined them previously, contained in the IQOS, which is the heat-not-burn device, and in normal cigarettes. And you can see you have 6 or 7 of these different carcinogens, but just if you take the first one, NNN, for instance, you can see that in normal cigarettes is in the range of 311, for instance, and that same carcinogen in the IQOS get down from 311 to 19. So it's a huge decrease in the content of carcinogens on these HPHCs. So the conclusion of that study is that these toxic compounds are not yet completely removed from the mainstream smoke of IQOS, so making necessary to consider the health effect and regulation of IQOS, but the presence is much less important. If we look at the same study made by the US FDA and published in July 2020, with their own facilities in their own lab, and these are totally independent studies, you can see that if you take this series of carcinogens, acrolein, benzoapyrene, formaldehyde, and so on, you can see that the decrease is in the range of more than 90%, because there is no combustion in the IQOS, and therefore IQOS will emit a very significantly reduced level of toxicant than cigarettes. So the conclusion of the FDA was that the exposure modification order for IQOS compared to normal cigarette would be appropriate to promote the public health and is expected to benefit the health of the population as a whole. So what is, if you switch from a cigarette to an electronic cigarette now, so we have these 3 systems, the snus, the electronic cigarette, and the heat-not-burn, which is called IQOS. You can see on that slide that there is a significant, again, decrease in the harm by switching to normal cigarettes to another one. And there is a very nice study published by Stephens and Cole, where they look at the order of magnitude of this reduced risk. And in that slide, if you look at the red spot, which is the main lifetime cancer risk for cigarette, you can see that e-cigarette is going to be less than 0.002, and heat-not-burn IQOS is going to be in the range of 0.02. So it's not just a decrease, it's a huge decrease, it's kind of risk cliff. So in conclusion, we know that cancer is a major issue in public health. We know that tobacco is the leading cause of cancer, was the leading cause, still is the leading cause of cancer in the world. We know that quitting is by far the best option, but is not very easy to quit. And all the current strategies to help people quitting have all failed. So innovation might bring us the solution for both helping people to quit and reducing the harm for those who cannot quit. Thank you very much.